Hello, everybody. Thank you, Mr. Ricker, for your introduction. I would like to thank Eric Herman for having asked me to participate. And now let's talk about literature concerning sagittal balance and disc arthroplasty. Here my disclosure. If you want to learn more about the different protheses that have existed and their evolution, you can watch the first webinar of JCO spine arthroplasty, where Professor Marc-Antoine Rousseau has been talking about the different types of arthroplasty. For those who prefer to read, you can have a look at a very exhaustive review and history of arthroplasty written by Fahem Sandou. Here is a table where you will be able to see all the different models of lumbar disc arthroplasty and the main study about each prothesis. Concerning sagittal balance, we can separate 4 types of balance spine according to Rousseau classification that you can see on the left, with low and high pelvic incidence. If you want to learn more about concerning this interesting subject, you can read a good article by Lehuec, which reviews the different elements to understand sagittal balance, like pelvic incidence, SVA, SSA, and T1 pelvic angle that you can see on the different figures. Understanding this data allows for better planning of surgical management of the patients and permits us to understand the complications like Johnson syndromes. Disc generation can lead to a lumbar hypolordosis or kyphosis, which may be the cause of an anterior sagittal imbalance. So the goal of this review is to define when the arthroplasty is a good indication in this case. I search on PubMed, and when you associate sagittal balance and disc arthroplasty, you can find 37 results, with 8 results during the last 5 years concerning lumbar or cervical. So now let me present you the main results. The first one I selected is a meta-analysis of 59 manuscripts included after a thorough selection and comparing functional scores and sagittal parameter with the aim to answer when the TDR is a good alternative to fusion. Lasnek and Lehuec found the same results, only the segmental lordosis significantly increased, about 10 degrees, and remained stable. No other significant variation, even in global lordosis, and no statistical difference comparing parameters between the 2 groups of TDR at 4.5 and 5.1. Concerning Tournier, his results differ. He concluded that the mean lumbar lordosis is significantly higher after total disc replacement, and the increase of L1S1 lordosis is neither linked with an increased angle at the prothesis level, nor with an increased range of motion at the prothesis level. Concerning Berg, he found significant differences in the fusion group at adjacent segments, with more translation and flexion extension, which is pejorative and can induce adjacent segment disease. Pellet and his colleagues studied the spinosacral angle that you can see on the figure to study sagittal balance. He compared it between fusion and TDR and found significant increasing for TDR contrary to the ALIF group, even if a lordotic cage of 12 degrees was used. So he concluded that arthroplasty appears to work most effectively at L4, L5 for all back types because it provides a better control of sagittal balance and better clinical results without affecting the lordosis of the underlying L5S1 segment. He advised for elevated sacral slope to use at L5S1 arthrodesis, which seemed to be more suitable. Here, the sources I used, and now a study by Strub comparing Rousseau's sagittal profile for TDR at 4.5 and 5.1. He found no change of the global sagittal profile compared with the pre- and postoperative X-rays, and significantly inferior scores for pain and function for sagittal profiles type 1 and 4. So that he concluded of a relative contraindication for lumbar TDR because of higher shear forces or loads on the posterior structures for these sagittal profiles. Another study, Maybloom and its colleagues studied the position of a mechanic prosthesis and found no significant association between anterior-posterior placement and the postoperative sagittal balance parameters. It determined a better functional outcome when TDR was positioned anteriorly to the center of the vertebral body, but these results concern a semi-controlled arthroplasty. He concluded that patients with normal preoperative lordosis had the best functional results, and TDR allows the preservation of a pre-existing balance. To conclude, for lumbar, TDR is a suitable alternative to lumbar fusion. It permits to prevent an ISD, the percentage that I found, and permits also compensatory mechanism. But we have to take care with these results because many studies with mainly mechanical prosthesis and no comparison with elastomeric prosthesis. Only standing full spine radiographies and no sit-in radiographies. Jean-Yves Lesnec going to talk about that. For finish, no advice concerning frontal disorder. Now let's talk about sagittal balance and cervical disc arthroplasty. Altered cervical alignment is a crucial factor in the progression of cervical myelopathy and adjacent segment disease and neck pain. OC2, like you see on the left, and C2, C7 angles work inversely. The C7 slope has a predictive value for the shape of the cervical spine in the sagittal plane. The median value is about 20 degrees, and patients with a C7 slope greater than 20 degrees have a lordotic cervical spine. Two studies comparing TDR, hybrid surgery, and fusion in multi-level cervical discectomy. On the left, the first one found no significant difference concerning global lordosis among the groups, but the authors determined for 3 or more levels a good clinical outcomes with TDR. And they conclude that TDR was not a good choice for large preoperative C2, C7 SVA, contrary to hybrid surgery that provides good cervical range of motion and restore cervical lordosis and C2, C7 SVA, but we must be careful because there was no significant results. In the second study on the right, the author found that cervical alignment was equivalently rebuilt among the groups. And the clinical outcomes were not related to the change. So he concluded that it was not essential to pay excessive attention to cervical balance. A last study published in 2020 concerning a viscoelastic prosthesis, they found that at the follow-up, there was no significant modification of the SVA. Thank you for your attention.